Okay, guys, I'm going to present your study guide in a PowerPoint format. I love it when my tongue doesn't want to cooperate. And without further ado, let's get this final review started. Okay, review for finals, your OB portion of the semester. The first thing that we wanted to talk about, because this is what we learned first, is our antepartum. So, there are things you should already know, so we're just going to review to make sure that we are reviewing. So when we have a mom or a pregnant mother that has morning sickness, what are some of our symptoms? Being nauseated not only in the morning, but also could be in the evening, could be late at night. They just call it morning sickness. It's not hyperemesis gravidarum. That is a complication that we're not studying about now. And so everything we're talking about right now just deals with the normal morning sickness that you see with the antepartum patient. A lot of times, just the smell of foods or just an obnoxious odor of some sort will cause them to be nauseated. There are some things that we can do to help these antepartums to have less morning sickness and hopefully no morning sickness, which basically is, um, because morning sickness is a normal part of being pregnant. We just want to alleviate a lot of the unnecessary morning sickness if we can. So remember what I taught you about things that we can do to prevent morning sickness. One of the things was to eat smaller meals, small meals throughout the day, not to be eating large meals. Um, Eating large meals overloads the stomach. With the baby being in there already, can cause them to be nauseated or vomit. Make sure that we are telling them maybe to eat toast or crackers before they get up out of bed, or even when they start feeling a little bit sick. A lot of times, salty foods can help decrease that nausea feeling and prevent them from vomiting. They should avoid eating greasy foods. Greasy foods are not good for them. That all that grease calls for the for the bile in the gallbladder to increase to digest it, and everything's sluggish in the antepartum. So we want to teach them to avoid that as well. Then we have appropriate teaching for specific gestational age. And basically what that means is that you want to be sure that you know what's appropriate for what age gestation. If you're talking about maybe them coming to a prenatal classes, maybe you're going to tell them, okay, we're going to start you on prenatal classes, and these are things that you need to we need to put you in this particular area of what we need to teach you in this particular stage of gestation. If you have a patient who's 8 weeks gestation, it doesn't do you much good to teach them about labor and delivery at this point. For one thing, an 8 week gestation does not mean she's going to reach viability. So the main things that would be important with an 8 week patient would be to maybe nutrition, prevention of morning sickness, how to deal with possible backaches as your uterus starts to come up out of the perineum into the abdominal cavity. Um, if you are in that second trimester, between the 12 weeks and the uh, 24 weeks, maybe you want to teach them other things. And even in the semester, there's different things. 12 weeks to 20 weeks, there's not a whole lot we can do about prevention of loss because we don't have a viable baby. Viability begins at 20 weeks. So we want to be sure that, maybe after 20 weeks, when we do have a viable baby, we want to teach them signs and symptoms of preterm labor so that they know what they need to concentrate on. When they get to 36 weeks, we would want to start teaching them about um, um, ways to alleviate a lot of the back pain that they're having. We'd want to talk to them about labor expectations, maybe do a birth plan. We would want to talk to them about maybe who they're going to pick for their pediatrician and options of type of analgesia for them. So be sure that you know the specific gestational age. And what about emotional issues about pregnancy? You know, um, right at when they find out that they're pregnant, of course, they're going to be hormonal. But when you found out that you were pregnant, it was kind of scary, wasn't it? You know, you don't know for sure. Oh my God, there's no going back now. I'm pregnant. I'm going to have a baby. What have I got myself into? You know, um, so how did you really feel about all that stuff? So be sure you're addressing therapeutical communications with the emotional issues that go about pregnancy, especially when you discover you're pregnant. You know, are you happy? Are you sad? Um, do you want to go through with the pregnancy? You know, was it a planned pregnancy? Are you, those sort of things. Nigel's rule, y'all need to know Nigel's rules. It's simply know the um, date of your last menstrual cycle and subtract 3 months and add 7 days. That's all you need to know. That's kind of just know it. Dietary counseling, be sure you know what foods to avoid. It's probably pretty pertinent right now after seeing Miss Kendler's videos on how many worms are in your food. Makes you want to swear off of eating anything, doesn't it? It's kind of like, oh my God. So you want to make sure that your pregnant person knows what kind of foods to avoid here as well. So they should be avoiding raw meats. They should not be eating raw fish. They should not be eating rare beef or pork or chicken because those things can cause them to have issues. And you want to be sure and catch those cheeses that have bacteria that grows in them, like blue cheeses, soft cheeses, gorgonzola cheeses, the types of cheeses that are real soft cheeses that actually have bacteria growing in them, and they can actually those types of cheeses can actually harbor the listeria bacteria that causes listeriosis. And man, listeriosis is a bad thing in pregnancy. So we really want to make sure that they're avoiding that. 6, 7, and 8 is going to cover fetal monitoring strip. So be sure that you know the definition for an acceleration, what causes an acceleration, know about your so accelerations are 15 beats above the baseline that last for at least 15 seconds. Those are your accelerations. For you to have a reactive non-stress test, you should have 2 of those in a 20-minute window. If you are late decelerations, you need to know that what causes a late deceleration? What does that mean? Is my baby hypoxic? Is it caused by placental insufficiency? Which it is. Your head compression usually results in the early decelerations that mirror the contraction, whereas lates come late in the contraction. You have to have a contraction in order to determine an early from a late. Your variable decelerations can occur anywhere along the line and drop down really sharply and come back really sharply. Please look at your definitions for lates, earlies, and variables that you know the exact 30-second how long it takes for it to go down, how long it takes to come back, and what defines them. So be sure that you're looking at that. Be sure that you know what would cause the baby to be tachycardic. This could be several things. Could be medication, could be maternal temperature. Be sure that you are looking at contractions as well as fetal monitor on the fetal monitor strips, that you know what tactosystole is. That tactosystole is when you have more than 5 contractions in a 10-minute window that causes the baby to not have enough oxygen because there's not enough relaxation in the uterus for the placenta to carry oxygen. And that completes your antepartum one. So let's go to the intrapartum. So what actions are appropriate for what stages of labor? Remember, you have 4 stages of labor. And the first stage of labor is from 0 to complete. Second is from complete to delivery of the baby. Third is from delivery of the baby for delivery of the placenta. And then recovery is your 4th stage. So during that first stage of labor, you've got a lot of actions to do as far as comfort for the mother goes, right? So you want to monitoring the strip, making sure the baby's okay. You're taking care of mom's comfort, taking care of her pain, doing things at appropriate phases in there. Phase 1, phase 2, phase 3, or phase 1 and actually the latent phase. We'll get this. The latent phase, the active phase, and the transition stage. So those are the phases that you're going to be seeing. And what are you going to do for each phase? In phase 1, it's what? 0 to 3. Then it's 4 to 7. And then it's 8 to 10. So those are, you need to know that, in the transition stage, it's very, very, contractions very close together. And it's very painful. They're ready to throw in the towel. During the active stage is when you're going to start seeing more pain increasing, and this is where you're going to start using your medications. Whereas in phase 1, you're going to use alternative methods to get them through because they're so early on in their stages of labor. So then you get to stage 2 where they're going to be pushing. So you want to know positions for pushing, closed glottis for pushing, support for pushing. So be sure that you know all those things. Then assessment of labor related to cervical dilation. How do you know a patient's progressing in labor if you don't check her cervix? So you want to be sure that you know how, if they're at 3 centimeter when you check them, 2 hours later they're 3 centimeters, they're not progressing in labor. If you check them and they're 3 centimeters, and then you check them again in an hour and they're 4 to 5 centimeters, then you know we're having progression in labor. So you always want to evaluate the progression of labor, especially if a patient says that they need to have a bowel movement. You don't just get them up to the bathroom and let them go have a bowel movement. Just because you checked them, they were 5 half an hour ago, you better check them again because they can always go to complete and you never know it. So what can a doula do and what can a doula not do? Doulas just cannot do any nursing functions. Doulas can support the mother, they can support the father, they can rub backs, they can rub feet, they can help them breathe, they can advocate for the doula or for the patient if they want to address tell the nurse that, the patient might need this because they requested it and she can make suggestions, but she cannot do what the nurses can do. She can't assess the contractions. She cannot assess the cervix. She cannot assess the progression of labor. She cannot determine when to call the doctor. All of that is the nurses. So be sure you know the phases of the stage 1 labor, and we've already talked about those, so I'm not going to talk about them again. Be sure you know about placement of epidurals, things that you need to make sure that you're doing when we are, before we have the epidural placed, during placement, and after placement. So before placement, of course, we always want to have a baseline. You always want to get a baseline vital signs of mom's blood pressure and her vital signs, plus the baby's fetal baseline. So you want to be sure you have those. And then you also want to get your bolus of fluids going. Usually anywhere from 500 to 1,000 milliliters of LRs infused before anesthesia. We'll even talk to you about putting the epidural in. Want to be sure that you're assisting them in position. Usually they're sitting on the side of the bed and you are helping support them. And be sure that you are monitoring after we get the epidural placed and they're put back in position. They're usually placed in a supine position with the uterus tilted. Be sure you're doing the vital signs every 3 minutes for at least 15 minutes to be sure that you're not having the hypotension syndrome going on. Don't forget that we should also, along with our vital signs, we should be doing that pulse ox because that's been a requirement for quite some time. And also, everyone in the room should wear a mask. So you want to be sure that you do that. Be sure you know how to do your Pitocin calculations. As several of you still do not know how to do that, and this is an easy point for you guys. Google this. There are some very easy explanations out there that might be more beneficial to you than what I've been trying to tell you. Sometimes we learn things in different ways, and some of them are done by students for students, and as long as they are done correctly, it doesn't matter what method of madness you use to get there. Just be sure you can get there. Okay, that concludes each part. Postpartum. We've talked about engorgement quite a bit and the difference between breastfeeding engorgement and then engorgement for bottle feeding. So you want to be sure that, with a bottle fed mom, the way we can prevent engorgement is, of course, the good snug fitting sports bra or ace wraps. If they become engorged, ice packs to prevent milk from producing. We want to, so because we're trying to suppress lactation and we don't want engorgement to occur. Usually, most moms have a little bit of engorgement regardless of what method, and so with like our bottle feeding moms, be sure that they know that when they start, if they do start feeling a lot of engorgement enough that's uncomfortable, that they can use ice packs. They can also use the cold cabbage leaves if they want to use them. Usually we save those for breast babies, but we can also use them for bottle fed babies. Breastfed babies, to prevent engorgement, the best way to prevent engorgement is to make sure that baby's eating. Make sure the baby eats quite often and empties out her breast. So, in order for, every 2 to 3 hours, and even sooner than that is a good thing, because the more they nurse, the more milk they make. But you also want to make sure they're emptying out what milk is in there. So the baby needs to nurse at least every 2 to 3 hours. She don't need to pump after feeding. The baby's the best pump she'll ever have, and it's going to help her make more milk. So, preventing engorgement, we don't really want to pump after feedings. We don't want to limit the babies on how long they can stay on the breast, and we certainly, want to be sure those breasts are getting empty out. Fundal assessment. Be sure you know how to do fundal assessment correctly. The technique of doing fundal assessment. A lot of y'all got caught on that vigorously massaging the fundus on the last exam. You never vigorously massage the fundus. You can cause it to go out of the pelvic and into the vaginal vault so it can prolapse. Another way to prevent prolapse and use the correct technique is to place your hand at the base, right above the mons pubis, spread out across her abdomen to maintain that. So look at the picture that's in your book in the postpartum chapter on doing fundal massage to learn what the proper technique is at if you don't understand it. You need to remember where the placement of the fundus is. It's 2 to 3 centimeters below right after delivery. Then around 12 hours, it creeps up to at least 2 at around the umbilicus, maybe slightly above, but it's not 2 to 3 above. It's just slightly above. So be sure that you know the stages of that. Uh, Be sure you know also with placement of the fundus, if it's off to the right, what are you going to do? If it's boggy and off to the right, what do we know is causing it? We know that there's a problem with um, an overextended bladder. We need to make sure that we empty the bladder, because if we don't empty the bladder, we'll never be able to massage the fundus down. So if she has a lot of bleeding and she's not able to get up to go to the bathroom, you need to either offer her a bedpan or uh, do an in and out cath, and then you'll be able to massage the fundus down. As long as that bladder is extended, we can't get the uterus into the pelvic cavity for where it's supposed to be for it to clamp down. So be sure that you're aware of that you don't massage first, you empty bladders first. All right. Hormones of breastfeeding. Know your prolactin and oxytocin. Oxytocin's your letdown. Prolactin's what makes it. Okay? Simple as that. Know how to set goals of care for the immediate postpartum. We want our postpartum patient to do what? We want her to be stable. So what are things that we're looking for? We don't want her to have heavy lochia, so maybe one of our goals in order to prevent hypovolemia, maybe one of our goals is to have moderate lochia. Patient will have moderate lochia by the end of third hour postpartum. Or other things that don't deal with bleeding. Maybe we want to have patient will be able to empty her void 300 milliliters, void at least 300 milliliters during first voiding by 6 hours postpartum. So be sure that you know how to set goals for that. Fundal placement of the postpartum. We've already talked about that, so you already know what those would be. Okay, up. Let's go to the normal newborn. Yay! You've already been over all this information, so you should know all this information. Though some of you don't know the norms of vital signs and what's reportable to the MD. Respirations are irregular. If they're over 60, we worry about it. And this is not during the first period of reactivity. First period of reactivity is all really strange. Everything's trying to transition. That first 6 to 8 hours, babies trying to go from intrauterine to extrauterine circulation, breathing, everything's trying to change. So the vital signs are real irregular and strange. But once that period of reactivity is over, the baby settles down, you need to know normals, anything below 100 in deep sleep is going to be not good. So 100 to 120 in deep sleep is fine. You shouldn't have over 160 at any point in time as far as heart rate goes. Respirations, the high of that is anything over 60. Always irregular. Babies do not breathe regularly, and their heart rate is not regular right when they're first born. They have some dysrhythmia. So what are some things you need to report to the MD? Temperatures over 100.4, respirations over 60. I'm not asking you to know the blood pressures. Respirations that include nasal flaring and grunting, heart rate that is extremely irregular, you would need to report that, murmurs, so things to that area. So be sure that you know that. So even though irregular breathing is normal, if you had a rate over 60, you should report that, because the rate over 60 is what is abnormal, not the irregular breathing. Circumcision. How to decide about circumcision. The American Academy of Pediatrics is what we go by as far as what governs what we do with neonates. They have issued, their last issue on circumcision was that although research supports the benefits and that circumcision is recommended, it is an optional decision that is made by the parents. It is not mandated. It is not supported as far as American Academy says do this. It says that it is beneficial, but again, the optimal decision is left up to the parents. So we as nurses, need to make sure that we are educating our moms that are trying to decide whether or not to do circumcision as far as the benefits and the risks. Benefits are, penile cancer is decreased, cervical cancer is decreased, UTIs are decreased, and so forth. So the decision is kind of left up to the mom. Later on in life, sometimes if they're not circumcised, they have difficulty voiding and they end up having circumcision anyway. So we need to teach that to them and how to make that decision. How do we manage circumcisions? Well, be sure that we teach them with the GOMCO. They have to put petroleum jelly They have to be sure to wash with just warm water and not soapy water. And then the Plastibell, they do not have to put petroleum jelly on it. Both of them, they need to watch for bleeding. Apply pressure if there is bleeding. Make sure they're peeing okay. Um, and again, don't use soap until the circumcision is healed. Be sure you know how to do an APGAR score. You've already had that. I'm not going over it again. Discharge teaching. Be sure you know what you need to report and what you don't need to report to babies or to the doctors about the babies. You had a multiple choice question on that. You may see something similar to that when we get around to getting the test to do the test. All right. So be sure that you know that. Fontanelles, be sure you know for the anterior fontanelle, posterior fontanelle, which one would close the soonest. The one in the back closes, a posterior closes at 4 to 6 weeks, and the front one closes around 18 months. Be sure you know how to do that weight assessment. Those of you who missed the percentage need to be sure that you are able to figure up how much of a percentage of weight loss there is. And a lot of y'all miss that. Be sure you remember that if you're doing it to the nearest hundredth, you drop it. You don't round it up or down. You just drop it. So basically, you're rounding down. So, bilirubin levels, be sure you know those. Anything over 12 should be investigated. Anything over 15 needs to be treated. And of course, if a baby's bilirubin is too high, will we send them home? We definitely, if the baby's billy needs to be treated, they're not going home. They're going to be staying for treatment. Good luck on your final. I'm sure if you study hard, you will pass with flying colors.